Welcome to the Faculty Lounge. I'm Paul Hauptman, Dean of the Graduate School of Medicine, and I'm delighted today to have Stacy Stephenson with me. Dr. Stephenson is an assistant professor and plastic surgeon in the Department of Surgery and a researcher in regenerative medicine. Stacy, welcome.
Thank you.
You know, one of the things that we've been doing in the Faculty Lounge is to talk to faculty members about the journey they've been on, and also to discuss something about their practice, their contemporary practice, and their research. So we probably should get started at the beginning, which means talking about how you started in the STEM field as a chemical engineer at Auburn University. Tell us a little bit about that, and then how you decided to pivot to medicine.
I was a latecomer to medicine. My plan was always to do engineering, but I did have the opportunity when I was in my sophomore and junior year to do, we called it co-oping, so cooperative education. And I am so old that we had quarters back then. So every other quarter I would work. And I discovered relatively quickly that the plant did not excite me, but the pilot plant excited me. And so I was like, I guess I like the research part better than I do just the daily grind of doing that. So I actually went back starting my senior year and was doing an emphasis in chemical engineering. And actually some of my friends that had been pre-med the whole time actually started to do some more interesting classwork. And as they were coming home and talking about it, I was like, oh, this is really good. And I liked some of the biomedical stuff that the biochemical brought me into. So I decided that I would look into biomedical engineering. And then after starting in biomedical engineering, I did a year of biomedical engineering before I went to med school. I was like, well, if I'm going to invent something, I want to be able to use it. So off to med school I went.
Well, that's a great story, and actually I think it ties to the current research that you're doing, and we'll get into that in just a few minutes. So you went north to, I want to say it right, the Ohio State University, where you went to medical school, but you did something interesting I noticed in your CV, and that is that you took a year between medical school and residency and did a postdoctoral fellowship. Tell, what did you study? Where did you study?
Actually, it was more about grants writing and paper writing. So I was a postdoc in the pharmacy department, and the particular professor that I was postdocing with had great people working in his lab, but they were great at the science and really bad at the writing. And he was up to his eyeballs in needing to get papers out and needing to get grants out. And it is, frankly, my least favorite activity. I don't think anyone really, really enjoys writing grants or papers, but I knew that it was something I really needed to get better at. And so that was the crux of the work that I did for him, was take all of the data that his great people had generated and actually got it into papers that could be published and helped him put into an NIH grants. So really just kind of helped offload that for him and get me into the groove of being able to not dread writing so much.
And it's a great skill to have, and some people have said it's a lost art, how to write a really good grant, how to write a paper that communicates concisely, and it's a challenge. It's not easy. I think we sometimes forget to train our trainees how to do that.
Yeah, I think especially we'll get all caught up in the language of it and not realize that even though the reviewers are going to be experts in their particular field, they might not know every little acronym that you put in or may not really care to know. But if you can explain it in a way that anyone can understand, it makes it a lot easier for someone to have a good impression of your paper, of your grant.
Oh, that's a great point. Especially as science becomes so super subspecialized, you can't expect to have content experts always reviewing your grants or always reviewing your papers. So you did a residency in general surgery in Baltimore and then opted for a fellowship in plastics at the University of Texas, the other UT, in San Antonio. Why plastics?
I actually started to become interested in plastics when I was in medical school. I had been out doing research and came back a little off cycle, so I did an elective first, and I did an ENT elective. And the ENT department at Ohio State was such that they actually did their own reconstruction. So they had microvascular trained ENTs. And I enjoyed the reconstructive part, but I much more enjoyed the reconstructive
interesting.
part.
Yeah.
So I knew going into general surgery that I was going to want to do plastics after. And I had thought about doing ENT, but I'm really glad, like most things in my life that I step into backwards, I did general surgery because since plastic surgeons operate all over the body, I felt much better prepared as a general surgeon going into plastics than I think I would have felt as an ENT than trying to step into a full plastics fellowship.
And in fact, now your clinical practice focuses on neck surgery, right, and breast surgery, reconstruction, and trauma. Tell us a little bit more about that practice. I would think that parts of it are predictable and parts of it are pretty unpredictable.
Yes, you can never predict trauma. And I was just on trauma call last night. But I particularly have a strictly reconstructive practice. My partner, Dr. Herbig, does some cosmetic, but majority reconstructive. And then Dr. Chun, our division chief, is more of a 50-50. But being strictly reconstructive, the majority of my work, tons and tons of breast cancer patients. Dr. Carlson keeps us very busy with head and neck cancer and consequences of the treatment of head and neck cancer with osteoradionecrosis of the mandible. And then trauma, a lot of that comes from ortho, but we also take facial trauma call. So we cover facial fractures in addition to what other trauma that might need soft tissue coverage.
Well, if I hadn't known any better, I would say you got a good night's sleep last night, but you were on call, so you're doing very well covering the work. There you go. So let's talk a little bit about what you're doing in the lab now. You're working with Tom Massey on stem cells. These are stem cells that are derived from fat, and you're looking to recreate bone with them. So tell us first about the source of the stem cell coming from fat and how easy it is or how difficult it is to get those cells to differentiate into bone cells.
Well, the process of getting them isolated from the fat is actually not too terrible as long as I don't provide Dr. Massey with too much material to work with. It's just a simple enzymatic digestion and then a couple of spins. And what you get is a pellet of cells that has the mesenchymal stem cells, but also a couple of different types of cells. Usually by passage 2 to 3, you've got all the other cells have died off because the stem cells grow better. And they take over the plate. We actually will check with immunohistochemical markers to make sure they truly are expressing those stem cell markers and it's not another cell population. And to get them to differentiate into osteoblasts and form bone only takes about 3 weeks with special chemicals that will actually drive them into the osteoblast lineage.
And is that process different if you were to derive your stem cells from, let's say, bone marrow?
The cocktail is actually quite similar that you use for bone marrow-derived stem cells versus mesenchymal stem cells from other sources, because they've also looked at cord stem cells. There's multiple, obviously, different sources for stem cells, but it seems that the cocktail that you use to drive those cells to a specific lineage may have a few tweaks, but baseline is the same.
So tell us what you're doing with the stem cells now.
So we are looking at a combination of not just the stem cells, but what we're putting them on, because cells react to their 3D surroundings. And so we're looking at different types of materials that can either potentially drive those stem cells without a cocktail, because in the body you don't have that special cocktail, to that osteoblast lineage or even a nerve type lineage. And seeing if we can either enhance their ability to become osteoblast or then maintain it once we then take away that cocktail. Again, when you want to put something back into the body, one of the things for stem cells is, well, what are they doing when we finally put them back in there? So that's one of the things that we're looking at to see if we can pair up those differentiations with materials that will continue to drive and support the growth of those cells. So that's what we're doing in the bone stuff. We're looking at particularly graphene and working with some great people over at the vet school and looking at various versions of graphene, because you can actually oxygenate it to different levels and seeing how that affects those cells' ability to maintain that bone lineage.
So would the idea be that you grow the stem cells on graphene and then transplant, for lack of a better term, the graphene into a human? Let's say you mentioned osteonecrosis of the jaw. Would that be
Yeah,
the goal?
so, and graphene is a thin monolayer material, but so it would probably be more of a coating on top of an implant that then you could actually, get bone growth surrounding. You could also potentially have a porous type material that's got graphene coating, like hydroxyapatite with a graphene coating, that then can go on to ossify and become bone. So ultimately, what I would love to do is have a Carlson patient come in, say, hey, I need a new section of jawbone. We take a CT scan, mirror the normal side of the jawbone. I go to Tom and say, let's 3D print this, and I don't have to take his fibula, and we can give them a healthy piece of bone. Because it does open up a world of options in terms of being able to really customize it for the patient, because no one's fibula really looks like their jaw.
Well, this is really the ultimate in translational research and personalized medicine wedded together. So we're very interested to learn more from you and hope that the research continues to progress. Of course, this means that you are the classic triple threat. You educate residents and fellows, you do research, and you take care of patients. So tell us a little bit about the challenges of doing all three in the contemporary medical world.
I will have to say, and I completely bought the lie, that you can be 50% research and 50% clinical. What you are is 100% both. And it is all about time balance. For me, the way my workflow goes is, especially when I'm trying to write, I need to not be interrupted every 5 seconds, which is a standard clinical day. So I have to hole out time where I am able to concentrate on, writing and that kind of stuff. So being able to realize your limitations, how your workflow works best for you, and being aware of the fact that you're not going to be able to do everything all the time.
And to some degree, it's also a challenge for researchers to get funded. And yet you're precisely the kind of person who should get funded, because the work is so practical and so important for patients. Well, so that was a really interesting discussion, and we thank you for coming to the Faculty Lounge, and we certainly look forward to having our viewers join us next time in the lounge at the Graduate School of Medicine. Until then, thanks for joining us.
Thank you.